Hi everyone, thanks for tuning in. I hope that everyone will watch this video before our class next week. So we're going to talk about oncology basics. Our objectives are to describe the process involved in the biology of cancer and to discuss the role of the nurse in prevention, detection, diagnosis, and management of cancer. Next week in class, we'll look at the different types of cancer therapy and complications. This is a slide that just depicts the number of estimated new cases and the estimated number of deaths of the different types of cancer. This is based in the United States. This comes from the American Cancer Association. This is men and women combined. There are a few differences between men and women. Generally, more men than women will die from cancer-related deaths each year. The mortality from lung cancer is higher in men. Cancer with the highest incidence in men is prostate cancer. Cancer with the highest death rate in women is also lung cancer. And cancer with the highest incidence would be breast cancer. Alrighty, so normal cell function, let's talk about that. Normal cell function involves proliferation, which is the period from cell birth to cell death, and differentiation. So proliferation includes something called the generation time, which is the time required for a cell to divide. And then when its population doubles, we refer to that as the doubling time. It's also influenced by apoptosis, which is programmed death of the cells, and something called contact inhibition, which is when the cells come in contact with different types of cells, they'll slow down or stop growing. The pyramid effect refers to the production of two or multiple cells during mitosis. So you have like 2 cells, then you have 4 cells, then 8 cells, 16, 32, 64, 128, etc. Differentiation. Pro-oncogenes, they normally function in a way that's much like the gas pedal, so it helps the cells grow and divide. And when a pro-oncogene mutates or changes or there's too many copies of it, it can become a bad gene that can become permanently turned on or activated when it's not supposed to be. And when this happens, the cells can grow out of control, and that can obviously lead to a malignancy. This bad gene is then called an oncogene, or you could say it becomes oncogenic. Tumor suppressor genes are normal genes that slow down cell division, repair DNA mistakes, or tell the cells when to die. When tumor suppressor genes don't work properly, the cells can grow out of control, and that also can lead to malignancy. So what is cancer? It is a defect in cell proliferation or a defect in cell differentiation. So in a nutshell, cancer cells proliferate at the same rate as the normal cells of the tissue from which they arise, but the cancer cells respond differently from the normal cells to signals that regulate cell proliferation and death. So the result is just indiscriminate or continuous growth. Cancer is also not a single disease, as you all know. It's a whole range of diseases with one common factor, and that common factor is just caused by basically a good cell gone bad. Characteristics of normal cells. So to achieve optimal function, each individual cell needs to perform in a predictable manner, and to do so, these cells need to have specific characteristics. First of all, cell division is limited and controlled. So cells divide with a purpose to develop new normal tissue or replace lost or damaged normal tissue, and their growth is orderly and well regulated. The cells will show a specific morphology. They have distinct and recognizable appearance. Their size and shape is consistent. They also perform certain functions, so every normal cell needs to perform at least one special function to contribute to homeostasis. For example, liver cells make bile, red blood cells make hemoglobin. When looking at the cell, they have a small nucleus to cytoplasmic ratio, so the nuclei are smaller than and there's more cytoplasm when compared to a cancer cell. They're also adhere tightly together. They're most cells will secrete proteins, and those proteins will bind them tightly together. And lastly, these cells don't migrate. They don't go where they're not supposed to go. So we just learned that a common factor in cancer is that the cells don't know when to stop dividing. But that also can occur in benign conditions. So some of those are in cases of hyperplasia, which means there's an increase in the number of cells of a tissue, most often associated with rapid growth. Hypertrophy is the term we use for growth that causes tissue to increase in size by enlarging the individual cells. And the neoplasia is uncontrolled cell growth that follows no physiologic demand. So there's new or continued cell growth, even if it's not needed for development or normal function. And let's see if I got some examples. So on your left and in the middle, we see examples of hypertrophy. So my little thing here. So here we see hypertrophy of the left ventricle, and here we see hypertrophy of the deltoid muscle. And then this is an example of hyperplasia. So endometrial hyperplasia is where the endometrium, this really skinny functional layer that sheds every month when a woman has a period, this just becomes thickened for one reason or another, and that's called endometrial hyperplasia. All right, characteristics of abnormal cells that are still benign. So these cells are going to grow in the wrong place at the wrong time or at the wrong rate. So examples would be like moles, uterine fibroid tumors, or polyps, nasal polyps. They do still show a specific morphology. Excuse me. They have a small nucleus to cytoplasmic ratio, just like normal cells. They still perform differentiated functions, and they're still held tightly together. They don't go where they're not supposed to go, and they grow in an orderly manner. The differences, I should say, for that is that they don't invade other tissue. They don't go where they're not supposed to go. Okay. All right. This is just a look at abnormal cells. This is a mole here on the left, and this is just an example of endometrial tissue, which this is normal endometrial tissue. It's just occurring where it's not supposed to be. So it's benign tissue, and the lesions strongly resemble the parent tissue, which would be in the endometrium, performs the same differentiated functions. So when these are under hormonal influence also, so when a woman would have severe cramping during a period or at the, prior to a period starting, they also have pain that originates from all these ectopic sites as well. All right, and characteristics of malignant cells. So malignant cells do not serve a useful function. They're harmful to the normal cells. They divide rapidly, almost continuously. They lose the appearance of the parent cell. They might become smaller, rounder. They're just a different shape. They also now develop this larger nucleus to cytoplasmic ratio. So you can see the nuclei are larger here. They lose their differentiated function, so they're not doing anymore what they should be doing. They lack that protein which is binding them together, so they're loosely bound. And these cells can migrate, so they have the ability to spread, to go where they're not supposed to go, which is referred to as metastasis, and that's a key characteristic of cancer cells. They can also grow by invasion, so they can invade the normal tissue they can invade normal tissue that's adjacent to the tumor. And there's no contact inhibition anymore, so there's nothing stopping these cells. Okay, this is the malignant transformation. There are stages of carcinogenesis. The first stage is initiation, where we have basically a normal cell that's now being exposed to some kind of carcinogen, chemicals, biologic agents, it could be anything, physical factors. Whatever changes it though, that's the initiation phase. So we then go into the promotion stage, and here the growth is enhanced, and promoters might be things like hormones, drugs, industrial chemicals, just really anything that you have continued exposure to. There's sometimes a latent period in before this promotion stage begins. Some cancers will grow very slow, like cervical cancer. Some grow very quickly, like pancreatic cancer. So the latency phase can be very short, or it can be longer. So once the cell's been initiated by that carcinogen and has cancer cell characteristics, it can become a tumor if the growth is enhanced. So now we've got the malignant tumor. So this is the progressive stage. And the key characteristic of this progressive stage is something called angiogenesis. So this is where the tumor actually establishes a blood supply of its own. So the tumor is, it makes tumor angiogenesis factor, and that stimulates the capillaries and the other blood vessels in the area to grow new branches. And so the tumor is basically being nourished now. And also here's where we see the formation of colonies or subcolonies. So you see the metastasis. All right, cancer in the immune system. So remember when we studied the immune system just recently, there are certain cells that are always busy trying to identify and destroy cells. So we have those natural killer cells and the helper T cells, which are most important for surveillance. The natural killer cells are going to act directly by destroying the cancer cells or by producing something, those cytokines or lymphokines or some kind of enzyme that's going to assist in cell destruction. The T lymphocytes are also going to recognize the tumor cell antigens, and they're going to promote or facilitate the development of other types of cells that can be toxic to the tumor cell. The immune system will fail if it doesn't recognize the malignant cell for some reason. The tumor antigens can also hide. I don't know if you remember, we talked about macrophages, and that sometimes they're supposed to, basically eat up the tumor antigen, but sometimes it can hide from them, and so it can continue to grow and multiply within a cell that's supposed to be killing it. So they can hide. Your body can become depleted of those natural killer cells or the T lymphocytes. And also there can be, when the host suppressor T lymphocytes, normally they just diminish the immune response. That's what they're supposed to do. And when they're no longer needed, they should just stop functioning. But sometimes they don't, and it's thought that maybe this abnormal amount of suppressor T lymphocytes might aid in the development of cancer. On to risk factors. So age and race are risk factors. So older women are more, colorectal cancer, breast, lung, pancreatic, ovarian. Older men, lung, colorectal, prostate, pancreatic, and gastric cancers. Genetics also plays an important role. It accounts for about 5, not more than 10% of cancers. So in this case, there's actually a genetic mutation. So the risk is pretty high for that person to develop cancer. Familial predisposition, this is where those pro-oncogens that we talked about a couple slides ago are passed on from one generation to another. So this isn't a genetic mutation, there's just a familial predisposition. So for those pro-oncogenes to develop into cancer, they will need to be altered by something that will lead them to be a cancer cell. So familial accounts for about 20% of all cancers. So you can see really that probably around 80%, 75 to 80% of cancer is just random. So when someone says that I don't have a family history, or we don't have any genetic malformations, just remind people that's great, but nevertheless, the majority of cancers just occur randomly. Exposure to chemicals, tobacco, alcohol, also exposures to certain viruses and bacteria, for example, H. pylori, mycobacterium, are bacteria that are associated with cancer, viruses, HPV, hepatitis B, herpes, all of those can be precursors to cancer. Chronic irritation. So chronically irritated tissues can undergo frequent mitosis. They're always trying to fix themselves. And so that puts them at an increased risk for DNA mutations. So sometimes you'll have for example, like a funny looking mole or an injury is a better example. And within that injured tissue, it heals up, but maybe it never really heals completely. But you can sometimes get a malignancy, like a skin cancer, inside that tissue. And environmental, it's thought that up to 75% of all cancers are related to some type of environmental influence: pesticides, formaldehyde, arsenic, asbestos. Also, the sun is an environmental problem, so sun or radiation exposure. And then finally, hormones. There's the administration of hormones such as estrogen therapy or estrogen and progesterone therapy are thought to, they can stimulate the development of cancer in some people, some women. Another example of that would be testosterone and the relationship of that to prostate cancer. Substances thought to increase your risk of developing cancer are having a diet that is high in red meat and fat and low in fiber. Alcohol. In women, just drinking 2 glasses of wine daily can increase your risk of developing breast cancer. Salt cured or smoked meats, and nitrate. So nitrate is an inorganic water-soluble chemical. So your body makes nitrates daily, but the majority of them come from your diet. And too much of this, too many nitrates, can increase your risk of cancer. So foods that have added nitrates include that ham, bacon, deli meat, hot dogs, those kind of things. Nitrates can be converted into healthy nitric oxide, however. So you can eat natural sources of nitrates like spinach, bok choy, lettuce, carrots. What else? Dark chocolate, arugula. I'm missing a bunch of them, but like beets, cranberries, those kinds of things can actually be healthy for you and reduce your risk of developing cancer. So high fiber foods, cruciferous vegetables, carotenoids, and possibly vitamins E and C, zinc and selenium. And, there's not a lot of evidence that supports that, but a little bit. So you'll see patients that take extra E and C for cancer prevention. Spreading of cancer. So local invasion is when the growth of the primary tumor, or when the primary tumor grows into the surrounding tissues. So this can occur because of mechanical pressure, so that the force, so that, let's say, for example, the tumor you have a colon, a tumor in your colon. So it gets so big, and let's say it's in the lower colon, or right even a rectal cancer. So when that force gets too much, when the tumor gets so big, it's going to force growth into other areas, like maybe into the prostate in males. So mechanical pressure, also enzymes that can destroy the surrounding tissue and allow the tumor to invade the surrounding tissue. Metastasis is the dissemination of malignant cells to distant sites. This can occur through the lymphatic system, through blood circulation, and of course we just learned about angiogenesis, so the tumor has its own blood supply, and also shedding of cells through, I forgot what I was going to say. All right, anyway, shedding the cells. So you can shed the actual cancer cells or even tiny emboli that can travel like into the body cavity and seed the surfaces of other organs. So a good example of that might be ovarian cancer. That's an epithelial cancer, so it's growing on the outside of the ovary. And so this is why it's hard to diagnose, because before it even gets to be a decent sized tumor, a lot of that has just sort of fallen off and seeded all the peritoneal area. So same thing with pancreatic cancer, since that organ is not encapsulated with anything, it's also just dropping cancer cells throughout the viscera. Lots of ways to diagnose cancer. You want to start with the patient's history, of course. You want to ask them about exposures or previous diseases, those viruses or exposure to those bacterias. If they had an ulcer that might have been a result of infection with H. pylori, you can ask them about if they, females, if they have a history of HPV, high-risk HPV. Also, males who have sex with males are now in some places being treated, getting pap smears just like women, so they also would be tested for HPV. Biopsies can be done. They can be a shave biopsy, needle, incisional, excisional, just depending on where the tumor is. Often they'll also look at the sentinel nodes. So if you are getting a tumor removed from your breast, they would probably take out several nodes, probably many, up to 6 to 10 of those axillary lymph nodes, because those are the closest lymph nodes to the tumor, and see if they're positive or not, and that gives you an idea of whether it's metastasized or not. Many other imaging studies, liver function, tumor markers. We'll talk about tumor markers in just a second. And genetic testing, which is readily available now. That paradigm shift occurred some years ago. It used to be you had to first go to a geneticist and give your whole history, get an order for the genetic testing, and it was really expensive. Now patients can get genetic testing on their own through various ways, or they can have genetic testing through their provider, can just order it directly. And then if it is abnormal, that's when you would talk to the geneticist and evaluate your risk. There's things online too where you can put in all of your family history and it will sort of calculate your risk. And those are kind of fun to do. So imaging, we've got tons of imaging, CTs, MRIs, fluoroscopies, PET scans, nuclear imaging, and all the endoscopies. So colonoscopy, bronchoscopy, cystoscopy, endoscopy, all of those things are done. All of those endoscopies, you're able to get biopsies. So the whole point of getting a biopsy is that you need that information because it's going to guide your treatment. So you can say, oh, I have breast cancer. But until that biopsy's back, you have no idea like how you're going to actually treat that cancer. Same with any other kind of cancer. And now with the biopsy, there's a lot of, you can look to see what the genetic mutations are within that biopsy. And that's where targeted therapy can help, because we now have some cancer chemotherapy drugs that will target just a specific type of mutation. So we'll talk about targeted therapy next week. So tumor markers, or what we call tumor markers, are they're circulating markers. They can be circulating in the blood, the urine, the stool, and this can help with diagnosis. None of these are good screening tests, so we don't use them for screening because you can have positive tumor markers for other reasons besides just cancer. But it can estimate the prognosis or determine the stage of cancer. We use them to monitor treatment. and also in some cases to identify residual cancer. So with calcitonin, we can measure that to see if a patient has medullary thyroid cancer. Medullary thyroid cancer is not the most common thyroid cancer. Papillary cancer is. And if, say, somebody had a medullary thyroid tumor, you took it out, you can do a calcitonin level after surgery to make sure that there's no residual cells there. The carcinoembryonic antigen, or the CEA antigen, is often used in colon cancer. So if your patient has a mass and your biopsy is scheduled, you'll also see a CEA being drawn. And if that's elevated, it gives you, you probably are dealing with cancer. The alpha-fetoprotein, or AFP, this is positive in liver cancer and germ cell tumors. CA-125 we use for ovarian cancer. CA-19-9, pancreatic, gallbladder, and gastric cancers, also liver. And CA-27-29, we see that in breast cancer as well. So what's happening here is that the cancer is really sort of, in some of these anyway, the AFP and the CEA, the cancer cells, you can see that things are kind of going back to its original fetal function. So the cells are acting like fetal cells again. So that's why you're seeing these pop up. They forgot how to be normal. All right, the ACA, the American Cancer Association, has specific warning signs. They use the mnemonic CAUTION. So the C is to ask patients about changes in bowel or bladder habits. And that is, a change in bowel or bladder habits is one of the first signs of colon cancer. The stools may get thinner, or the patient may have more diarrhea. Then A is a sore that doesn't heal. U is unusual bleeding or discharge. So a good example of that is endometrial cancer. So in like a postmenopausal woman, they should not be bleeding. If they are bleeding, you could say that they have endometrial cancer until proven otherwise. Also, like abnormal vaginal discharge can be an issue in women who have cervical cancer. But unusual bleeding from like a sore that doesn't heal would be 2 warning signs. Thickening or lumps in the breast tissue or even elsewhere. So you would feel, for example, in someone who has a lymphoma, you might be able to feel that swollen lymph node or nodes in the neck, under the arm, in the groin. Ingestion or difficulty swallowing. We always think of this as in terms of having a gastric cancer, but also if someone has a thyroid cancer, a thyroid growth, sometimes those will grow posterior, so the patient may complain of difficulty swallowing. But if someone complains of those things, they could be simply just have a hiatal hernia or a stricture, esophageal stricture, but you can't know that, so you need to send them for an endoscopy. An obvious change in a wart or mole, generally speaking, you should have like all the moles that you're going to have by your mid-20s, by 25, 26. So if you start getting new moles and you're 40 years old, you shouldn't be getting a new mole. So that would need to be checked out. Or if the mole you've had forever starts to change. And then that nagging cough or hoarseness. All right, cancer characteristics. They're classified by the tumor of origin. So carcinoma and adenocarcinoma occur in the epithelial cells or of glandular organs. And sarcomas, soft tissue sarcomas in the joint tissue, fat tissue, muscles, fibrous tissue. There are a lot of different subtypes of sarcomas. A bone or an osteosarcoma, an example of that would be Ewing's sarcoma, so that would be in the bone. So it's soft tissue sarcomas and bony sarcomas. We have melanomas, which occur in the skin. Actually, I shouldn't say that. Melanoma can occur anywhere. I've known of people who have had a melanoma on their spinal cord, in the spinal canal area, also the back of the eye. So they can pop up other places. Leukemias are blood-forming cells or blood-forming cancers. Lymphomas are lymph gland origin. Multiple myeloma, we know, are plasma cells, so cancer of the plasma cells of the bone. Let's see, there's a lot of lung cancer, so I'm just going to add this in here. But so adenocarcinomas are the most common type of lung cancer, like 40 to 50%. Small cell carcinomas account for about 15%, and large cell about 2 to 10%. And I'm only saying that because you'll see that in your cancer patients on there when you do your chart review or whatever. It'll say adenocarcinoma of the lung or small cell or large cell, and that does depend. Their prognosis depends on that, and of course their treatment. Clinical manifestations of cancer. So when you're asking your patients those constitutional symptoms, when you begin your subjective assessment, you're asking them if they've had any unintended weight loss, loss of appetite. They should not be losing weight without trying, and people should not lose their appetite. An appetite is a sign of a healthy person. So losing an appetite is a sign that something could be wrong. Nausea without cause, unusual fatigue or weakness. So you have to say, have you had any unusual fatigue? Because everyone's going to say they're fatigued, but are they fatigued to the point where they're not able to get up in the morning, where they're calling in sick for work, where they can't, walk the 2 miles a day that they used to walk, or things like that? And then you ask about pain, but pain can be a late symptom in many cancers, such as pancreatic cancer. By the time you have pain, it's pretty far gone. Same thing with colon cancer. The colon can accommodate a lot of bulk, so you're not going to feel a small tumor. You're not going to feel it till it starts to get in the way of the stool moving through. Same with bleeding. People always think of bleeding as a manifestation of cancer, of colon cancer, but bleeding is a late symptom, and only about maybe 10% of colon cancers will ever have overt bleeding. So while it's one thing to check for the stool for occult blood, that could be negative, and you could still have a whopping cancer in there. Grading cancers, grading is the first step in confirming a cancer. So you're doing what's called the histopathology. So histo means tissues, pathology, disease. So you're just looking at the disease that's in the tissue. So after you get a biopsy or an excision, whatever kind it is, you need to see the histopathology report. That's going to tell what type of tumor it is, all the different specifications of that tumor, and that will guide your treatment plan. And then there's different degrees of differentiation, and so you'll see things like poorly differentiated or well differentiated. If it's well differentiated, it'll say G1, G2 is moderate differentiation, and G3 is poor differentiation. So if it's a poor differentiation tumor, you're going to have a poor progress. Next one. All right, staging. So tumors are staged. We use the TNM mnemonic, or it's actually a staging system. So when you look at the tumor, you'd get a 0 if there was no evidence of a tumor. That would be awesome. Or it can be a tumor in situ, for example, if it's in the duct of the breast. So ductal carcinoma in situ, meaning it hasn't penetrated the duct and gone into any of the other any of the other tissues. Or it can be a tumor 1, 2, 3, or 4. And this is an example of a colon cancer. So you're measuring it, and I don't know exactly what the measurements are, but it's in centimeters, like 1 centimeter, less than 2, less than 3, and so forth. So, so they can grade that. So you'll have a T 3, for example. And then nodes are no nodal involvement whatsoever, or you have 1, 2, or 3, and this has to do with the number of nodes involved, and this will give an idea of the extent of spread of the cancer. So it might be a T3N0, and then metastasis, it's either metastasized or it hasn't, and that information you get from your scans, so the PET scan or CT scan or whatever sort of scanning you're doing. All right, prevention, we're almost done, I hope. I think primary prevention, so we have primary prevention and secondary prevention, but primary prevention includes avoiding those carcinogens, so avoiding excess sun or tobacco or pesticides, harmful chemicals, wearing sunblock, adopting a nice healthy diet and exercise. We know that exercise is good for cancer prevention. Also, patients who exercise during cancer have a better prognosis, better response to some treatments. Let's see what else is underneath there. Yeah, having a healthy BMI, limiting your alcohol, avoiding those risky lifestyles. So safe sex comes to mind. Avoiding exposure to the environmental hazards. So if you work in an industry, farming or pest control or something, you should be wearing the appropriate PPE to keep yourself from being exposed. Skin protection, early removal of abnormal skin lesions. So having those checks to see what is, if something is precancerous. And surgical options for some genetic carriers would be a form of primary prevention. So if you had, or female, you had a BRCA1 or 2 gene, you would consider having bilateral mastectomies and having your ovaries taken out, ovaries and tubes. So a whole hysterectomy is what would be done. So you're doing that as a preventive measure. And then also vaccinations are considered a primary prevention. So vaccines, an example of that would be the HPV vaccine and the hepatitis B vaccines. And secondary prevention, the early detection and treatment, which I just said. So going to all the screening, your screening, so that would be, skin cancer screening every year is a good example. Cervical, breast, lung, colorectal, and skin cancer treatments. All right, let's see. I think that's it. There's the cancer vaccines. We also have treatment vaccines. So the BCG, Provenge, and there's other treatment vaccines or immunotherapy that is also being developed. So, for example, the HPV is associated, persistent infection with high-risk HPV, I should say, is associated with cervical cancer. We know that mostly because of when the vaccine came out, that's what it was for. But that high-risk HPV, the same types are also associated with head and neck cancers and colorectal cancers. So we know that the vaccine can offer some preventive protection, but also looking at the vaccine's being looked at to see if it can also perhaps be used in the treatment of those kinds of cancers. And your screening recommendations, whatever they are. Breast cancer, your screening is with a mammogram, and that's still the American Cancer Association and the OB-GYN Association still recommends annual screening beginning at age 40. Your biggest risk factor for breast cancer is really with age. So if someone is 50 and they just decide to stop having mammograms, they're sort of missing the highest risk time in their life, so it's not a good idea. Colon cancer screening, the age for colon cancer screening is now down to age 45 because of so many younger men and women getting colorectal cancers. And so a colonoscopy, if it's clean, and once every 10 years. If there's polyps, depending on what kind of polyps they are, it might be that they need one every year, every 3 years, every 5 years. Prostate screening, men at the age of 50 should have a digital rectal exam annually. I should also back up to colon cancer. Even though the colonoscopy is the gold standard, everyone should probably have one colonoscopy at least, because you can biopsy the polyps or remove them. But we do have Cologuard and some other tests that can also be done. The Cologuard picks up cancer DNA, so it's gained a lot of appreciation and use in the last few years. And they just added more DNA types to it too. So if someone doesn't want to have a colonoscopy, they at least should get a Cologuard. All right, prostate screening. So the PSA test is not routinely used to screen for prostate cancer, but it's typically done on men around the age of 50 and then periodically thereafter. Cervical cancer screening, we know we need to have a pap smear and specifically an HPV test. After the age of 30, you're testing specifically for the HPV, even if they have a normal pap smear. Pap smear should start, when they become sexually active. It doesn't need to start at 16 or 17, but they need to start at age 21. And then I think it's every 3 years now up till the age of 30, and then every 30, maybe it's every 2 or every 3 if you do the HPV. The HPV is what's causing cervical cancer, 98% of it. So if you have a negative HPV, your risk is pretty low. And maybe someday we'll just be doing the HPV. Lung cancer screening, if you have a 30-pack year history of smoking, you should be getting an annual CT scan of your chest. And then screening for genetic mutations, you want to, you should be asking patients about you always are asking them about their family history. So, if they've got a lot of different cancers in their family, or for example, if there's a male that has breast cancer, you might be more prone to think, oh, maybe they've got a, BRCA1 or 2 gene in that family. So, and patients, like I said, they can opt to do genetic screening on their own. In pregnancy, you guys probably learned that there's multiple options for screening during early pregnancy and also before pregnancy. All right, and that is all I have, I think. So we're going to talk about cancer treatment next week. Hope you all have a great day. Bring your questions to class. Bye-bye.